All right, welcome everybody to our second course about space management. This one was a little bit too extensive, a little bit more comprehensive, took a lot more time, but this one is going to be concise and straight to the point, only one subject we're discussing. The idea is to do the hands-on training, basically familiarize it. I wouldn't want to call it training, it's not that much of a training to be involved. It's very simple, straightforward, easy way of doing a space maintainer. And the idea is to get you guys familiar with it and also review some of the background about space management, which you probably already know a lot of it, but it's always good to give you my own comments and my own experience, because I wanted to basically make this more like me giving you my experience about this specific subject. I did not get any of these slides from any textbook. It was all from my experience and from my background. So a lot of tips that I'd like to share with you. Hopefully you can either take them or modify them, or and hopefully you will find it a very useful presentation. First of all, obviously the objectives here is just we'd like to define the objectives. One is to review the space management indications, techniques, and to establish hands-on competency with this chair-side space management painting technique. And I'd like to make a disclaimer in the beginning that we have no commercial interest, although we are providing some instruments, kits that may have a brand name on them, but doesn't mean that we are endorsing that specific brand name. We're not getting any discounts, any gifts, or any kind of perks from any commercial entity or any company, just so we can be clear on that. That's important for the sake of getting the credentials from the ADA CERP, because hopefully by next time I'll be CERP certified, so we can give you actual CE credits. So the first question is, why do we maintain? Why do we need to maintain? This answer is in one slide. This is what happens if we don't maintain, we lose space. And then in this case, the second premolar did manage to erupt in a lingual position, very awkward, extremely crowded situation here. Obviously, it will be a big job for an orthodontist to correct something like that, but many times the premolar gets even impacted and completely blocked, won't even make it through until you extract the first premolar or do something surgical to either allow it to erupt. So that's obviously the reason why we maintain. It's very important that we do understand, and as I'm sure you guys already know that, but it's always good to emphasize the space management importance. Now the dynamics of space loss, obviously, there are several factors that I listed here that I could think of. First one is location, which means the location of the tooth. Which tooth is we're talking about? Is it anterior versus posterior? Is it a first primary molar or a second primary molar? And the timing of the extraction that would indicate the space maintainer, the timing of the occlusion, the development of the dentition, is it primary dentition, mixed dentition, the age of the patient, all that plays a factor, and we will talk about that as we go. The type of occlusion plays a factor, whether it's a class 1, class 2, if it's crowded, if it's not crowded. Also, we'll discuss that as also crowding, and of course, if the patient is an active ortho, then that will make life a lot easier for us. Then that will be usually the orthodontist problem or job to take care of space management if they're an active ortho. Okay, location, anterior versus posterior. Obviously, when we have anterior tooth loss, we don't need a space maintainer. That's very clear. Everybody knows that. And then the reason is why, because we say that the anterior teeth are good neighbors. They don't occupy each other's space, and so anterior teeth, no need for space maintenance. However, I have seen a very extraordinary case, very unlikely to happen, is when there was severe crowding and the child lost an anterior tooth because of an abscess and extraction, and as a result they ended up because of the crowding with one single incisor in the middle which is something that, you know, a parent may question you in the future, why didn't you do something about it? And it's something that we'll keep in mind if you have a child that has severe crowding and lost a primary tooth. You could we can. I mean, you could always refer them to a pediatric dentist to just get it off your back, take that responsibility off your shoulders. But most likely what will happen is we will tell them there's nothing that we need to do about this. At this point, he's going to need braces. We don't usually do space maintainers for anterior teeth, but if you want, we can do, if the parent still would like to do something, if the child is cooperative enough to let us do what's called the aesthetic appliance. When we put a Pontic on the front, it can act as a space maintainer and as an aesthetic appliance at the same time. Very unusual, very unlikely to happen, but it's just, I thought I will mention that. Otherwise, in general, no space maintenance for anterior teeth. And the same thing here. We mentioned the anterior tooth loss plus crowding. You can either explain what I just said to the parent. They want to have that aesthetic appliance with that Pontic to make it look nice, and also do a space maintenance. If it's really crowding and there's a concern, you could say, or you could refer them. Like here in this example here, this is my 3-year-old son. He lost his front tooth, fell down, bumped it, knocked it out. And you see all the spaces here, plenty of spaces that we have in the front. And I'm not worried about him losing any space. But there he is. We don't do space maintenance in this case. Posterior, obviously this is where the need for space management is. Obviously we have unilateral versus bilateral, and critical versus non-critical, which means if, depending on the things that we just mentioned before, the timing and the location and the type of tooth is involved. The timing, which is the most critical. Number one is before eruption of first permanent molars. Obviously, this is the most critical time to manage the space and maintain it. If it's a first primary molar that was lost before the eruption of the first permanent molar, let's say the child is only 3 or 4, you do have a couple of years until they're like just before 6, before the eruption of the 6-year-old molars. If you don't do a space maintainer for a couple of years, nothing will happen. Sometimes we tell the parents, if the patient is not under general anesthesia, if he's under general anesthesia, we do the space maintainer at the same time. But if they're not, and we have to do an emergency extraction due to an abscess or gross caries in his unrestorable tooth with symptoms and all that, and the child is only 3 years old, and it's okay, you know, we still have a couple of years, you can wait till they're about 5 and a half, then it is very important that we do a space maintainer. We make sure that the parent understands that they can bring their child for that. But that space maintainer is extremely important, because once the first permanent molar erupts, it obviously will start pushing the second molar, and you will almost certainly lose the space. So that is the critical time just before the eruption. If you have the space maintainer there, then you'll know that your space is maintained before the eruption of the first prime molar. When we're talking about a second prime molar, it's a different story. Obviously, it's a distal shoe in this case. And now it's something what we would want to do at the same time of the extraction. Again, if the child is under general anesthesia, it's simple, easy. We do a distal shoe space maintainer. Again, the technique we're going to be learning here is something we can do with chair side within 10 minutes, hopefully. Not much of a learning curve. I don't think it's just a simple process, and it's almost always we always have to do it at the same time of the extraction, because you have the socket still did not heal. Once the socket heals, it will be very difficult to try to basically cut into the gingiva and insert that distal shoe extension there. So always do it at the same visit, and depending on the cooperation of the child, you could do a distal shoe space maintainer from a very cooperative child to a mildly cooperative child to a little bit uncooperative. If they're completely out of control, there's no space maintainer they can do. And the type of patient who are kicking, screaming, grabbing things, jumping, they may end up it will be a risk for them to swallow or aspirate the space maintainer, and we'll tell the parents, say, I'm sorry, we can't do this. This child is extremely uncooperative, and we just can't do it. So and we'll talk about, I will walk you through the phases and the stages of doing. I'll start from the minute the child walks in to the operatory with a need for an extraction. We'll talk about the extraction. I'll tell you my technique, how I do it, and how we approach the child from the time that they come in, do the extraction, do the space maintainer, and even the anesthesia. Now, we're talking, by the way, although I put removable here, but we do not do removal at all. I don't do it at all. It's something that used to be taught in textbooks. I don't think it's a practical thing. The child is going to take it out of their mouth. Is not going to keep it. It's not going to do the job. So I would say removal is out of the question. I don't think any other pediatrics that I know of that uses removable space maintainer. So we're talking only here about fixed. And then the unilateral fix is either a band and loop or distilled shoe. Obviously, there are only two types of unilateral fix, and that is there's a code. Obviously, you need to know when you bill out for a unilateral fixed space maintainer. The code. Salah will probably know what's the code for unilateral fixed space maintainer band and loop.
That's
what?
1510.
1510. He knows the code by heart, so there you go. So that is a fixed unilateral space maintainer, band and loop, or distilled shoe. When we're talking about the bilateral space maintainer, it's called bilateral fixed. Also has different code off by one number, and then again, no removable, only fixed. Bilateral fixed has a code, and it's either a lingual arch, a Nance appliance, an upper lingual arch, or a TPA transpalatal appliance. Now, the two most commonly things that are used is a lingual arch for the lower and a Nance appliance for upper. However, I am starting to personally, after all those years, I'm starting to trend towards using an upper lingual arch instead of a Nance, because basically you get the same effect with the upper lingual arch. I'll show you a picture of it now. And you avoid the impinging on the gingiva with that button that could cause inflammation on the palate, and that could cause sometimes a patient can come back with an emergency because of the inflamed palate, or food getting stuck between the button, the Nance button, and the soft tissue, and can become a problem. So an upper lingual arch is a lot more hygienic and will do the same job. It's basically a lingual arch, but it's on the upper, and I'll show you how it looks like. Where we do not have to maintain, obviously, we talked about anterior teeth, over-retained extraction when we have a tooth that's already erupted and the primary tooth is still over-retained. Obviously, we don't need a space maintainer. When we have a class 1 molar relationship and no crowding, then they tell you, always teach you, no need to do a space maintainer. However, in my opinion, especially as a general dentist, if you err on the wrong side, if you do a space maintainer, nobody's going to hold you responsible. Why did you do a space maintainer on a class 1 not crowd? Nobody's going to question that. But you could be questioned if you do not do a space maintainer and the child ends up with a space loss. So although it's something to keep in the back of your mind, if you have a class 1, no crowding, then you could get away without a space maintainer. But if you do it, it will be no problem. When we have generalized spacings, it's very rarely, but I've seen very few cases when we have completely no contact point. And obviously, the only reason we will lose space is because the teeth are against each other, leaning against each other, and you take one and they start shifting to close the space. But when there's all spaces, there's no contact point, you don't have to worry about space management. There are cases when you see, I've seen teeth being extracted either by a general dentist or whoever, they come to me and I've noticed that space maintainer was not placed and there's no space loss. I can't really pinpoint besides that what other reasons why they wouldn't lose space, but that could happen. They could get lucky and there's no spaces lost. But in general, we have to keep in mind that expect always to lose space. And obviously, we talked about the very uncooperative child who would grab instruments, jumpy, who would, there's a risk of them aspirating or swallowing the space maintainer. You don't want to take that chance. We could do an extraction on a very uncooperative child, but we cannot do a space maintainer on a very uncooperative child. There's a big difference between the two. Now, I'd like to start from the beginning with the psychology of the extraction. From the minute the patient walks in, the child comes into your room, and there are several things that we have to be really concerned about and address as we do this. Now, if you remember from the last presentation, I mentioned about 80% of children of your patients are cooperative and expect them to be cooperative. When it comes to extractions, I think the ratio is a little bit different here. It is more likely that you have someone who is uncooperative for the extraction versus someone who is uncooperative for another different procedure. The reason why is because we have here, we're talking about extraction, we have the fear factor. You have a child coming in, they have this fear of the unknown. They're worried. They've been told they know that they're coming here for an extraction most of the times, unless if you're lucky enough and you have a mature parent who knows how to handle the situation. They don't really over-prepare their child. But most of the time they come in, they know that they have an extraction done, so they have this big fear there. So you have to take that into mind. You have to work on that fear. You have the parents' influence, which is the biggest problem, is the parents' influence, because they come in and most of the time say, well, you're coming here to get your teeth pulled. Your teeth are getting pulled. And I'll give you a couple of extreme examples. I actually heard one parent telling their child, they're going to yank your teeth out of your head. I mean, they use some. Yeah, that kid is extremely scared when they have a parent like that. I have a funny story that actually sounds almost like a joke, but I had a child that was 6-year-old little girl that was very cooperative for her dental work, and I mentioned, I say that story a million times because it's unbelievable. And did the first visit, first quadrant, she did great, very nice, perfect model, cooperative child. Did the next visit, the second quadrant, the same thing, great, no problems, no issues, very cooperative, no crying. The third time she comes in and she won't even step through the door, let alone she won't even sit in the chair. Very scared, panicking, frightened. And I'm asking the parent, what was going on? Did somebody scare her? And one of her brothers or sisters tell her something? And they say, I don't know. And then all of a sudden it's like an epiphany came to there and said, oh yeah, she watched that horror movie, The Dentist, last night. And maybe that's why. And that's really, I mean, imagine a 6-year-old little girl watching the horror movie. Apparently there is a horror movie called The Dentist I heard about, where the dentist, a crazy dentist, goes and kills people with his instruments. And she watched that movie, the horror movie, before she came to me. And she's complete, I couldn't even touch her. So that's an extreme example. So you have to work with, I mean, obviously it's not that bad usually, but still the fact that the parent always say the wrong thing to the child. They're gonna stick you with a needle, they're gonna take your tooth out, they're gonna pull your tooth out. So the child coming, they sit in the chair, first question is, are you gonna pull my teeth out? So you have to work on that. I'll tell you what I do, or they'll tell you, what are you gonna do to me? What are you gonna do to me? So the fact that they're thinking in their mind that you're doing something to them, to me, not to my teeth or even my mouth, to them they're feeling threatened as a whole. And I got one kid that he sounded like the Godfather's grandson. He was like, oh, hey, what are you gonna do to me? He was talking like he wasn't. I thought maybe he was an Italian or something. But what are you gonna do to me every time you come? Hey, what are you gonna do to me? So I mean, it was really funny, the things that I go through, but you also, those are the things that you have to, sometimes you feel like you have to undo bad parenting in a few minutes in a chair, but something, I'll tell you what I do usually. Now, obviously, what is your influence, is what the dentist's influence is, to hopefully undo what the parent has done and try to enter the child's world and talk to them, use their language without talking down to them at the same time. So what I do is first, the first patient comes in and sits in his chair. I'm getting my teeth out. Are you pulling my teeth out? Are you taking my teeth out? The parent also did their comment. So I say, no, we're not pulling any teeth out. What are we talking about? They say, and the first thing, obviously, you don't want to lie to the child. We all know that. Number one, because you lose their trust, obviously, and the parent, it's like you're the worst thing ever if you ever tell them something and they do something different. They can do it, but you can't. So so no, we're not pulling. I say, we're not pulling your teeth out. We don't pull teeth out here. I don't like my teeth to be pulled. Do you like your teeth to be pulled? No, of course not. You know what we do instead? We wiggle them out. It's a lot easier than pulling. And then they get something. Somehow you got their attention because they want to know now, what do you mean by wiggling out? And I say, I'll show you how. And I usually hold the child and I say, imagine if you have an apple tree, and if you wiggle the apple tree, left, right, and I just kind of move them, wiggle them like this. And what happens to the apple? If there's an apple on the tree and you don't want to pull the apple, you just wiggle the tree and it falls off by itself, right? And they say, yeah, so that's exactly what we do with teeth. We just wiggle it out and it falls off by itself just like the apple. So somehow you kind of and I see that working. It does work, I'm telling you. So the child somehow now at this point, he is thinking of the tree, and he knows that we're not pulling teeth out. We're doing something completely different. Sometimes even the parents like, oh, really? Oh, wow. Oh, that's interesting. A lot of parents get it, and they kind of smile at you, but some of them were like, oh, really? That's what you do instead? Oh, interesting. So now we give them anesthesia. Now anesthesia, obviously, the way I do it is, and I'm sure everybody, each one of us have your own technique of not showing them the syringe or the needle. And the assistant passes the syringe behind the headrest, behind the patient headrest, so they don't see anything, no visualizing whatsoever. And a lot of them would want to go and like try to look around and see. And I have it very calmly, quietly under the headrest. If they move around, it's in their blind spot behind their head. There's no way they can see it. When they go like this, they go like that now, and just holding it behind their head. So they go like this, going like that. So they can't see the needle, and they don't see the syringe. And then we put the topical anesthetic. Now I'll mention something to you about the topical, a very potent. I don't know if you heard of TAC. Anybody uses TAC here? Heard TAC? Okay. TAC is a great, very potent topical anesthetic. You could leave it there for a few minutes and almost like giving a local injection. It is very.
Could you repeat the name?
TAC, T-A-C. I'll give you the formula. I'll tell you how to order it in a minute. So that if you put it, leave it for a few minutes. If you have time and you want to leave it for a few minutes, then you actually, they almost never feel the injection. Almost never feel it. Unless you have something extremely apprehensive and the slightest thing, they will just jump out, very jumpy. It's a different story, but they almost never feel it. So I get it from behind their back, from the headrest. I block their eyes with my big hand, and at the same time use my fingers to retract their cheeks, and I go like this in and out. If it's infiltration, go like this, same way. Big hand blocking their eyes, fingers retracting their cheeks. Her assistant hand is over the patient, in case he moves, he won't grab it. So she's prepared with that, without the patient noticing that somebody's having their hands down in a very passive way. So in case they move, she knows what to do. In and out real quick. I call it this, that they didn't know what hit them, anesthesia. So once that happens, then they're fine. Most of the times they're okay. They know they feel numb. You know, to talk about that, how you feel numb and all that. Show them in the mirror. Nothing happened to your lip. If it's everything is good. If everything is still the same, that's how sleepy lip feels like. And then we do the extraction. And then I do the wiggle song. And I say, you want to listen to my wiggle song? And I grab, and they see me passing, trying to hide their forceps also at the same time. And they see me passing the forceps. And I say, what's that? What is it? Oh, that's the wiggler. That's the wiggler. Don't worry about it. I'll show you how it works. And before I even put the wiggler in your mouth, I'll show you with my fingers how it works. And I put my fingers on the tooth, and I say, we're going to play the wiggle song. Wiggle, 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 wiggle. Left, right, rock, rock, wiggle, wiggle, left, right. Now, a lot of the parents is happy. They're happy that you're talking their language. That the child is kind of smiling, even though they were scared. And I'm telling you, it really works. And they say, okay, let's do it with the wiggler now. We get the forceps, we get the wiggler. And I tell them, always tell them, very important, you're going to hear a crunchy noise. Because the last thing you want to know is they panic. They hear the cracking noise of the tooth, they panic. So you need to make sure that you prepare them for that. Now, Joe would tell them, crispy rice?
Rice Krispies.
Rice Krispies. And I don't know if they will get it, Rice Krispies. So I tell them it's going to feel like you're going to hear a crunchy noise, and it's going to sound like this. I make that noise with my mouth. And then my assistant looks at me funny, but she thinks I'm being silly, but I think it works. Because I want to be as explicit as possible, and I want them to know exactly what to expect to the maximum. So when they hear that cracky, crunchy noise in their mouth, they don't feel like their jaw's bone is getting broken. So I don't want them to panic. So I tell them, I'm going to hear a crunchy, cracking noise. It's going to be like that, like. I go that with my mouth. So now everything, there's nothing new. So now we eliminated the fear of the unknown factor, so we don't have that anymore. They know they're being wiggled. They know there will be pressure, because I also tell them that when I put my fist over their shoulder and I push on it, feel the push, it's going to be like that. Push, it's going to be a push like that. So they know about the push, they know about the pressure, they know about the wiggling left, right, from the wiggle song. They know about the crunchy noise, the cracking noise. So there's nothing new. So at this point, you go proceed with extraction and you get great results. And that's what works for me. And I'm telling you, you could try that or do something different, but Most of the time, the parent gets very impressed. I hear a lot of compliments, a lot of positive comments, feedback from the parents. The child is happy with science. Of course, not always, and there always will be the ones who are going to be crying, still scared. That but by far, it works for a big percentage on them. Now. When we have a very uncooperative child and we have a patient that needs extraction, we have an abscess, especially if it's on lower, it's an emergency. We see the patient, we do the extraction on the same visit. I don't care. We don't give antibiotics unless there is a swelling, of course, a facial swelling. If there's no such thing and it's only localized abscess, especially with a draining fistula, then we do the extraction on the same visit. Whatever, no matter what the child's behavior is, no matter how uncooperative he or she might be, we do it on the same visit. It's an emergency. We tell the parent, we'll let them know, especially if it's on lower, it could spread, cause a serious problem. So we always manage to give anesthesia, even if we have to hold them down. We have to do it. This, that's an exception to holding children. It's very quick and easy. We give them the injection, whether it's block or infiltration, while the parent is holding them, and we do the extraction one way or another. Always, no matter what. Even if there are times where I just put the forceps on the tooth and I do nothing, and the child goes like this and the tooth is in my hand because it's just so violently moving that I didn't have to luxate it. I mean, it happens. But you always have to be careful, obviously, putting your other hand to make sure they won't aspirate the tooth. You have to put, sometimes I put a gauze, also a 2x2 or 4x4 as a curtain to make sure it won't fall back down their throat. There was a time when I had to do extraction on a child that was standing up against the wall, actually, and we just had to do it. When there is an abscess, we do it. So that's as far as the extraction. Now, not the same thing applies with a space maintainer. Obviously, when then you can't do a space maintainer because it's not as easy. You need, even though it is fast with this way that we're going to learn now, but it is not. When they're very jumpy and moving forward, it's not going to work. Now, this is the tack that I was talking about. When you have a very mobile tool, this is the formula. If you take it to any compounding pharmacy, they will make it for you. It's a lot cheaper than ordering from a company, a dental company, because otherwise it's very expensive. This is a lot cheaper. You go to a compounding pharmacy and tell them you want this tack, or they call it tack 20 because now it has 20% lidocaine. And this is the formula to give to the pharmacist. And I think this is a great tip because every very mobile tooth that is, some of them are hanging by a thread. You obviously don't want to give a whole injection, a topical injection to a child for a simple extraction on a very mobile tooth that's over-retained, that's bothering them because they're being discomfortable or causing them some pain because it is loose and they can't chew. So you don't want to give them a whole injection. You usually put the tack for 5 minutes and they don't feel anything. I guarantee that to you. It's like I use it every single day. I mean, every single day I use tack for these reasons. And of course, depending if it's a simple thing that only takes you, I do it with a gauze usually. You need a forceps when something like that. But with the tack, you leave it there for about 4 to 5 minutes, and you get a very good anesthesia, more than enough to extract a very mobile, loose, over-retained tooth. Now back to the space maintainers world. The bilateral fixed space maintainer is a lower lingual arch. Basically, you put the bands on and probably basic knowledge for you. Probably already know all that. Bands on the first permanent molars, and that's how the lingual arch goes, resting on cingulum of the anterior, lower anterior's permanent teeth. Obviously, you have to have anterior permanent teeth. If you don't have them, then you can't do it. And the only other option you can do is a lip bumper. Lip bumper is a little bit more of an issue than this. So. But you can still do it. You can still do the same way. You put the bands, take the impression, send it to the lab. The lab will send it back to you, and you can cement it. Now, there are also, just like there is a chair-side unilateral fixed space maintainers, there are also chair-side bilateral space maintainers, like a chair-side lingual arches. I don't use them personally myself, but they may work for you if you want to. That's another option. But again, this is not what we're here for. Basically, this is what it will look like, the lingual arch. Once you send it to the lab, you take the impression, you put the bands exactly where in the impression, as if they came out with the impression. You send it to the lab, it comes back after a week, you cement it, and that's what it looks like, and you got yourself a bilateral space maintainer. And I think that the fee for is over $300 for that. And again, cementing it as 5 minutes, taking an impression in another 5 minutes. It's really a simple, good source of production for you. This is what the NANS looks like. This button is a little bit too big, but but that's what we've been doing all along when we have a bilateral space loss. Now, we do have the option of doing 2 unilateral fix. That's also possible. There's nothing wrong with that. You can either in this case, they already lost space here, but either that or you can do 2 unilaterals. Even although you can do 2 unilateral fix instead of a lingual arch as an option. Now, this is the upper lingual arch that I talked to you about. This is the upper arch, and see, they made the lingual arch and it's resting on the cingulum of the upper teeth. And that works as good as an ants, except it has the benefit of no, the button that would impinge on the soft tissue on the palate and cause inflammation, and a lot of time you have to take it out because it's severe inflammation and food impaction. You don't have to worry about it with this lingual arch, upper lingual arch. I've done it before to correct a single tooth crossbite, because what you do is if you have a single tooth in crossbite, obviously you want to open the bite so it will not be interfering with the movement of the tooth, and then you make a simple appliance like this. You see the loop here? You activate the loop by opening it with a straight plier, and that it will push the tooth in a crossbite and forward. And I've done single tooth crossbite correction with this upper lingual arch, but now we can also use a space maintainer if it's passive. And now this is my tip. We deal with such a good lab that I do not even try the appliance before insertion. The appliance comes to me clean and dry. I give it to my assistant, she cements it, and I put it in the patient's mouth. And 9 times out of 10, it fits perfectly like a glove. Because I thought about it, if I were to try every appliance, and I know 9 out of 10 it will fit, 9 times out of 10 it will fit perfectly, and I spend, let's say, 5 minutes in each time to try it on, and oh, it fits good, and take it out with a band remover, then dry it, and then put it back, cement it back on. That takes extra. I counted and I added all the time. It will cost me a lot more time than if I had 1 out of 10 appliances that I had the cement already on it, it didn't fit, and I have to take it out, clean the cement out, and make some adjustment on it before I glue it back on. So don't try it if you have a good lab that you work with and you know they do a good job. Just cement it as it is, and you save yourself a lot of time. And I do the same. By the way, I went a little bit off this subject, but when I have a patient that comes to me referred by another dentist, and I know that we know somehow, whether from records or the patient, that they have taken x-rays, whether it's bite wounds or whatever, from the other dentist. We make one simple, easy attempt to collect that, to get that, a copy of that x-ray, either by calling them or asking. If we don't get it straightforward right away, we tell the patient, listen, it's not going to be easy for us to get a hold of your doctor or your dentist to get your x-ray, but we're going to take our own x-ray, and it will be at no charge to you or to your insurance as a courtesy, especially that we have high definition digital x-rays that will give us a more diagnostic, possibly a more diagnostic image that we need. So what you did here is you scored a point with the parent that you're doing something as a courtesy, free of charge, and it's not costing you anything. The system will take in 1 minute. You have a good quality image. You didn't wait and waste this time. I mean, I don't know, I don't even understand why some dentists would want to wait and waste so much valuable time to get the x-ray from the other referring dentist if you can do it for free. So that's what we do in our office. Anything that takes to save time, especially if it's costing you any much. So we don't want to get hung up on, paying for the x-ray. Now this is what the unilateral flex is an example of a lab fabricated one. Now this looks really nice. This is a very nice example of a lab fabricated one, nice and shiny and polished, but they don't always look this good. I've seen them. I've seen the lab ones. I've seen a lot of them that were done by a general dentist. By the way, do you guys all send to the lab for your space maintainers? Do you do? No, none of you do shared site. Okay, so when you send it to the lab or you do it by yourself, obviously a lot of you and the lab technician is trying to make the loop wide enough so the tooth can erupt in the middle. And I think the chances of that happening is like the chances of winning the lottery, because most of the times it's going to get stuck. If the tooth really erupts, it gets under the wire. And it's not a big deal if it happens. And you take the appliance, the tooth will self-correct its path. Usually when the factor that's interfering with eruption is removed, it will erupt if it's a little deflected, it will still erupt fine. So it's not a big deal. Now, to me, when I put a space maintainer, and especially this type, to me it's like an engagement ring to the parent, because the first question they will ask you when you're done, doctor, is this going to come off by itself, or is this tooth is going to push it out? I said, no, no. This is something that only we can have, we'll have to take it off. And that's why it is very important for you to keep your 6-month checkups, so we can keep an eye on it. So now we give them another good reason for them to be meticulous and careful about coming every 6 months. So if the tooth is going to erupt in 2 years, you got 4 more guaranteed visit of them coming. Make sure they're going to come back for their recall visits. So here, the other disadvantage of the unilateral, of the lab fabricated one, is by the time you send it to the lab and it comes back maybe 2 weeks, in 2 weeks you could lose some space. So you really want to do it sooner than 2 weeks. So that's another disadvantage. The other disadvantage is obviously the waste of time. You waste your time. You take this time that you take the impression, fit the bands, take the impression, dismiss the patient, send it to the lab, and have them come back on a separate visit, and then insert the space maintainer. So you skip all that with one visit when we do this technique that we're going to learn now. Chair side, this is an example of a chair side. As you see here on a typodont, basically it looks good. Now see the rest here on that, there's a rest on the loop. I don't do that rest, so you can ignore that. I'll tell you what to skip from, because they sell them in kits and they offer you so many options. I'll tell you what to skip on things that are just useless and things that really work. And I'll show, this is an example. This is one, I actually took this picture with my iPhone. We did the space maintainer about 2 or 3 years ago. And they came in a couple of weeks ago. I remember we were doing this presentation. I thought, oh, great, I'm going to take a picture of that with my iPhone. And it looks good. A couple of years later, I'm fine doing this job, doing the space management without a problem. So that's what you have with the chair side that we're going to learn. This is a picture, by the way, bite wing off. We took it in our office. That was not, we don't do post-op X-rays on either, even on the distal shoe, or obviously on space maintainer. But this patient was treated possibly in the OR, but came back for a recall visit. We took the recall bite wings, even though, to be honest with you, you don't need bite wings here because you got crowns and you got no spaces, but somehow the assistant took it routinely. But here we go. We have a space maintainer here, fitting perfectly fine. You see how it's resting against the canine and doing the job without, when the first premolar, see on the bottom, on the lower, it's erupting. It will be doing that at the same time on the top, and then when that happens, then you have the critical time is being secured here with that space maintainer. Another angle here of a different space maintainer. See how the loop will show. You see the insert, that loop is going in the inside the tube here, and you can see it on the X-ray. And that's what we're going to do today. We're going to insert it in the. There's a band that is carrying 2 arms, and each arm has like a tube in it that you can insert that loop in it, and you crimp it, and you got your space maintainer, and you can see it on the X-ray. That's a distal shoe, an example of this shoe that was done. Also, another routine biting that was taken, and I did this distal shoe space maintainer. And I'll teach you my own actually tricks and tips about how to make this work for you. And you can see how it is coming right inside where the distal root was. It's in perfect position. Now sometimes you can have it right resting against and I've seen. I had X-ray when it's resting right against the mesial surface of the premolar. That is acceptable, that's fine. But this is like really ideal. It's exactly where the root used to be here on the distal root of the second primary molar. So that's a distal shoe space maintainer. Now, what we need here is, again, you have everything. We got to make sure everybody has one. We should have one for everybody. A kit for the space maintenance for upper and the lower. That can be purchased from different types of vendors. You could choose your vendor, not necessarily the one that's on this here, but you have your kit which has those kind of different sizes bands, and you have those loops. Now the loops that they offer are either the ones with the rest that I showed you before, which you don't need, this kind of a loop, which you don't need either, and there's the one that they call it drop liners, which you have here in this kit, and this is the only one that you need that to order. We'll talk about that as we go when we do the hands-on. This is the crimping plier. You can see it here. It's right here on your crimping pliers. There's this one here, and you use that to crimp. Once you insert the tube inside the loop inside the tube, you crimp it, and it's secure. It gets almost like welded to the tube, and you make sure it won't come off. Now, The band pusher, that's the band pusher that you need to push the band. And this is the only thing you're gonna need. Obviously, you don't need the bite stick, which is this one here. You don't need this one when you do it on a type it on here, but I thought I would show it to you, bring it here, and have it with the instruments, because that's what you're gonna need. You probably, I'm sure you guys use that in your offices, but that's what you need when you have them push on the bite on distal or buckle to seat the bands. Between the pusher and the bite stick, you got all you need for them to seat the bands properly. Now we're gonna show you a video of how I did it. I picked up a very cooperative child, an ideal patient here, and I literally did it in 5 minutes here from A to Z. And we'll go through it. We'll see if you have any question about that. So very nice cooperative child. We just extracted tooth T on her. It had an abscess. You see the space is still a little bloody because the extraction, she just bit on the gauze for maybe 10 minutes. So it's not fully clotted, but you can still do a space maintainer even though it's not fully clotted. What we do normally is, if you're doing only a space maintainer, it's usually double booked for a 15 minutes appointment. Or if it's an extraction, you do the extraction, you have them bite on a gauze for 20 minutes. You actually buy yourself time. You can go away for half hour if you have to do something else. You see another patient at the same time. We do that all the time. Okay, we did the extraction now. They have to bite on the gauze for 15 minutes, 20 minutes, whatever. And we'll come back. You can see another patient do another procedure and come back and do it. So now what I did here, I'm sorry, let me go back a little bit because I'm... Okay, so here I'm trying the band. I asked my assistant, it looked like a 37. I told her. What I tell them first, let me just pause it for a second here. What I tell them is, first of all, and again, this is tell, show, do. This patient is exceptionally cooperative. Not all of them are like that. A lot of them need to know what's going on, obviously, so they won't, no surprises. Again, that's the keys in pediatric dentistry, is no surprises, and make sure they acknowledge everything and they know what you're doing before. So I get that band that you have here in your kit. I put it on her pinky and I say, look, it's just like a ring. It's going to give your tooth a big hug. See, feel how it's hugging your pinky. That's how it's going to be hugging your tooth. So they know that there's something that would be, see, feel the pressure on your finger. That's the kind of pressure you're going to feel on your tooth. So that's number one. We show them how it works, tell, show, do. And then we pick up, in this case, I told my assistant it looked like a 37, and it turned out to be right. Sometimes you have to go half a size because they come in half sizes or a size below, or if it's really loose, it's like a size or maybe even 2 sizes less, or if it's really tight, it's a whole size or more. But if it's just about, or you can almost fit it, but it's just a little bit off, then you could go to the half sizes. So here in this case, we tried the 37 and it fits fine. Now I fits fine. I took it with my finger, but it's better to use your, I had a good grip on it. I managed to take it with my fingers. For you, Bobby, if you're not doing that every day like I do, you may want to try do it with a band remover, which we have right here. A band remover. You own, I'm sure you know what that is. So now here I got this tube here. I got the loop. I told my assistant to give me the loop, and I cut it. This is a cutter. Now here we have a heavy-duty cutter, but over there there's a special dental cutter. That one is $150. This one is $10. So for the purpose of training, this will do. So I cut it here, as you see, and I'm inserting it inside those arms. See how easy it is? It gets inserted very simple, very easily. Now I got it in. I'm not crimping it because once I crimp it, I can't manipulate it anymore. I can't extend it or do anything with it. Once it's crimped, it's kind of locked in. So now it's short. So I'm going to extend it by pulling it out a little bit. Pull it out a little bit, make sure I make sure that I make up for all that space that's there. And now it looks like it's fitting. But I'm going to give it maybe half a millimeter extra to compensate for using the 3-prong plier. We're going to give it the curve. See, I made it slightly overlapping, like maybe by half a millimeter, just barely overlapping. And it looks like it's fitting fine, because what's going to happen, let me pause that for a second here. What's going to happen is I'm going to give it a curve to make it match the curve of the gingiva, and also it will help to when you have the biting forces, and the load of the biting forces will get distributed on a curve versus having it straight, and you have less likely for it to impinge on the gingiva. So when I use the three-prong plier, I give it that curve, and it will automatically get shorter because you give it the curve, it will get shorter. So I compensate by make it slightly longer, like maybe half a millimeter, just a little over the edge longer, so when I do the curve, it will fit perfectly fine. Now, if you decide not to do the curve, that is fine. You can still do that. You can still have a functioning space maintainer as long as it's resting on two teeth. You can have that, and it won't be a big problem. If you want to make it really ideal and perfect, like I do it here, then you can do the curve. But if you find it hard, or you're finding it that it's every time you do the curve with a three-prong plier, it's getting too short for you, it's not working fine, then you can just skip that and just do it straight. I've seen it happening straight, and it works fine as well. So what I did here is, after I made sure I got the right length, I crimp it. Now it's locked in, it's not going to go it's not going to get out of the thing. Now I get the three-prong plier, I can give it the curve. See how that works. And the same thing on the other side. I'll do it on both sides. See how that works? A little bit more of the three-prong plier on both sides. Give it a nice curve. It looks really pretty this way. And you have a ready space maintainer. You're ready to cement it. I'll try it one more time, because when I did the curve, I want to make sure it didn't get too short. Sometimes it gets shorter. By the way, if it gets shorter, you can go with the same three-prong plier and do the opposite bend. When you do the opposite bend, you extend it. Instead of giving the curve, you kind of decurve it. When you decurve it, you can make it long again if you want, if it got too short. Now I dry it with the cotton roll. Give it to my assistant. I'm using that cement, that Fuji Sem 2. That's simple and easy, because it's I have a dispenser that goes straight to the band. But if you want to use your own glass iron cement, the true glass iron cement is probably more preferable than resin modified glass iron cement like this one, because it has more ability to release fluoride, and you want to prevent decalcification with a fluoride releasing glass ionomers cement, especially if you're cementing this on a permanent molar. Now this is getting cemented on a tooth number 30 on a permanent molar. We want to make sure we're using a glass ionomer cement to release fluoride to prevent decalcifications. So I dry it here, got the saliva ejector, the air water syringe. I put a little cotton roll. If you want, sometimes I don't even put a cotton roll. Got it nice and dry. If it's not perfectly dry, that's fine. It doesn't have to be perfectly dry, but wherever you can. I see now, push it in place. Okay, take out the cotton roll. Take the pusher, pushing it on the distill. You see, I mean, that girl is just too good. But see how that happened? Pushing it, distill, mesial buckle. Then wipe the excess cement with a wet 2x2. This is the bite stick, obviously, because the pusher is not going to give you everything. The pusher is not going to give you exactly what you want. It's not going to seat it perfectly where you want. So you always, sometimes you can accomplish everything with a pusher, but most of the time you need the band seater, which is the bite stick also that you have here. And once they bite on it, you use the tip of the triangle on the bite stick, and you put that tip of the triangle on the edge of the band, and it asks them to bite, and then it will seat just really nicely. Some of them bite excessively hard, and they can go a little bit deeper, but then most of the time they just have the right biting force to get it where you want it to be. Wipe it with a wet 2x2 for the extra cement. You don't want to use suction, because if cement is still soft and you use suction, you will suction out the cement out of the band. So you don't want to do that. You can use a saliva ejector, because it will not is not strong enough to suction the cement out of the band. See, now you got a nice space maintainer cemented, fitting perfectly. Everything is in great shape. She's all set. I double check it with the Explorer. If there's any excess cement in the loop, I flick it off with the Explorer. And it's all done, end of story. That's the whole space maintainer on the same visit of the extraction. And the last thing I do to make it pretty, this is just my OCD nature, is I push in the groove, give it a bend on the groove with that pusher, and make it look as if it was custom made. And that was all set. Now this video took 6.5 minutes, including the explaining. So the whole thing took less than 5 minutes. And that's something you guys can do. Let's do it right now, actually. Everybody has a kit? Okay, good. So the first thing we're going to do is some of you have an upper, some of you have a lower typodont. So we're going to do 3 types of space maintainer. We will do a space maintainer for extracting a first priming molar, either a B or an S or an L. We're going to do a space maintainer for extracting a second priming molar, either a J, K, or T, and we're going to do a distal tooth space maintainer. And we can all do them here. I think we have enough of these things. So let's start with let's extract if you have the upper, extract A or J. If you have the lower, extract K or T by unscrewing it out from the typodont. So just unscrew one of these. Just take that. If you have, sorry about that, you have to take off that foam, the tape, and use screwdriver to remove the tooth that is. Just unscrew it from the back.
Yeah.
From the back.
It's the second.
Yeah, second. Or the first. I'm sorry. Do the first, whichever. Do the first. Let's do either a B, I, or L or S. First priming molar. Unscrew a first priming molar first. Okay. You have now an extracted tooth. You just did an extraction at your office. Okay. Now we want to fit a band. So you open the kit. If you have an upper, open the upper drawer. If you have a lower, open the mandibular drawer. And now you're at your office. You're trying to pick a size that will fit the right size band for that priming molar. Now it's going to go. The band is going on a second priming molar. If you're working on the upper, it's going on tooth A or J. If you're working on the lower, it's going on a K or a T. So pick one that will fit. If you find it too loose, we don't have too many sizes here, but we have the most common sizes for that. If you find it too loose, go to a next size. If it's not, you're going to find resistance, and that's what will happen with a real life patient. You're going to have resistance, so that's when you need to put the pusher and push it in the contact area. The pusher is the one that looks like an elevator. That's the pusher. Looks like a tooth elevator. Yeah, and then we'll push it, and does it fit good? Mm-hmm. Good. Well, you made sure that it fits good here on the first. Now you're doing it on, okay, you're doing it on a first priming molar. That's fine. That's fine. He's doing on a. That's the same thing. But we want to do this also. So that's good enough. That looks great. That looks great. I'm gonna just walk around and make sure everybody got it right. Does it fit? Fine. Okay, good. You got it. Perfect. You use the pusher. Great. That looks great. Excellent. Let me see. Did you? Yeah. Did it fit? Did it fit? Did you try it on?
Yeah.
Is it too big? That's too big. Go a smaller size. What size was that?
32.
Yeah, go to a 31 or.
No, I don't have 31. Oh, 32 and half,
Yeah.
32.
Yeah, that's a smaller size. That looks like it's fit, but you have it upside down. There you go. Okay, good. Get the pusher now. Not with use the pusher. You don't use your finger. That's the pusher. Same thing here. Yeah, use the pusher because you have tight contacts. You need a pusher. You have to have a pusher. And probably fall on the floor. Okay, same thing. No, this is if they are binding. If they're binding, you want to use this. But if you're using the pusher here, just use that and go. Yeah, yeah, it's not too tight. You think it is. That's what you have. That's what you can have. You have it upside down, by the way. You want to make sure that's facing down. It looks too tight, but even on the patient, it's not. You use your fingers. And you go like this.
Oh, okay.
And it got put. So that's what's going to happen in real life. Now, when you take it out, don't use a band remover. And just go like this. Always, if you have a patient like this, have your finger behind it, so you want to secure it so it will not like drop in their throat. And go like this, and you got it out because it will go like this here. Once it's.
Okay, wait a second. Which side do you tell? Which side is the gingival side?
The gingival, it's just like it is written. Upper, see, it has a concavity.
Okay,
Yeah. So you want to go and there, try. So first, with your two fingers, try to push it down in the contact point, and you get a little bit, even if you get a little stuck, and then use the pusher to get it in more, and then use the band remover to take it out. Everybody got it in the right place. Now you want to take it out. Now you know the first thing you did at this point is that you have the right size band, and now you need to take it out with a band remover. So everybody has a band remover. Just take it out with a band remover. Just be familiar with the band remover in case you don't use it that often at your office. So take out the band remover, use the band remover and take it out. And again, pretend that you're working on a patient. If you have an upper, pretend you're sitting in a, whatever you work in, 11 o'clock or 12 o'clock position, and use your finger behind your left, that's what I do. I use my left finger from my left hand to kind of secure in case if it falls off, I will grab it with my left hand. So let's say if I'm working on an upper patient here, and I'm working in the 11 o'clock position, I put my finger here, and I go like this. I mean, this is my way of doing it. Whatever you feel comfortable doing, to make sure that you have it secure, and then you use the band remover to basically take it off like that. And can I have that band back here? I'm gonna try it, put it back on to show everybody. So now we have the right size band that fit. Again, once again, I use my fingers, 2 fingers, to give it a little push. Once I have a little enough that it's got stuck there and not all the way in with my fingers, then I use the pusher to make sure it's seated fine. And it looks like I got it right. This is the right size for sure. And then many times I don't even do this because with my experience, we've done thousands of those. So I don't even do this, to be honest with you. As soon as I put on a tooth personally, I go like this and I say, I know this is the right size band. I don't even do that. I take it out. I know this is my right size band without even use the pusher. But if you want, you could use the pusher to make sure it's in the right place. You got it. And if you want to even try it, you can have them bite on the bite stick. That's the tip of the triangle. And I say bite, bite, like I did in the video. I'll show you the video again. Bite, 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 bite. It fits fine. So now we use the band remover. If you want to take it off, to put it, you bend like this. You got it out with the band remover. So there you go. So now we accomplished the fitting the band. We have the right size band. We have we took it out with the band remover. Now we're going to we asked the assistant to pass, or you could pick it up yourself, the loop. Now we get a loop, and this is the only kind of loop you need to buy, by the way. Don't get distracted with buying the ones with the rest. They really kind of not have much use to them. Don't buy the ones that are straight, because I prefer the ones that you see here in your kit, because they have that curve. That curvature, basically, it gives you a 3D interface with the opposing tooth, versus you have a straight loop with only two dimensions. You have a 3 dimensions here. So it's like you're having something like this. If somebody's leaning against you and you're holding them like this with like a hand, you have that kind of effect with the 3D. That's why I prefer, that's the only type that I like to use, basically. And it's more forgiving this way if you don't get it perfectly against the tooth, because you have a 3D, you have a wider, more space that's resting against the opposing tooth. Then it's more forgiving if you don't get it perfectly where you want it to be. You can still get the space maintenance that you want. So now you cut it. Apparently everybody knows to do that. Use a cutter. Here we have this heavy duty cutter, but you may want to buy the one that's a dental cutter. A little bit more expensive than this, and that you cut it to estimate how much space you need, and then you insert it just like I did in the video, and then you try it in again and make sure you got the right enough space where you want it to be. Okay, insert it. Sometimes if you insert it too long, you may take it out and want to cut it again to make it fit again because it's too long. Sometimes you find that you cut it too short and you push it and it's too short than the space that you have. And if that happens, you extend it, you pull it out with your finger, extend it out a little bit. And even as long as you have like maybe a couple of millimeters of that wire inside the arm, then you have enough to crimp on it. You don't have to have the whole entire arm inserted inside the tube to get a crimp. It would be nice if you have it, well, yeah, okay, but it's not that important as long as you have enough to crimp it with a plier and secure it there. So now you try it again, and you make sure you have the right length. Did everybody, let me check, everybody okay with establishing the right length for the space? Okay, that's good. Actually, you got it great here, because now you have extra. See, you have extra space. This is a little bit too long, but this will work good when you give it the curve. But when you give it the curve, it will automatically get shorter. And when you get shorter, you have the perfect fit. So you see what he did here? He made it a little bit longer than it should be, maybe by 1 millimeter longer. And if you want to do it straight, that's fine. You could do it straight, but you want to have to make it shorter in that case. If you want to give it the curve that I did to basically minimize the possibility of it being pushing, impinging on the gingiva from the occlusal forces, and make it look pretty, of course, matching the gingival line. Then you would use a 3-point plier, as we will show you, and you have make it slightly longer, so when you give it the curve, it will get in the right fit. If you want to keep it straight, fine, you can keep it straight. It will still do the job. So now you can go ahead and you can either crimp it first. Yeah.
Get the distance that you want.
Yeah, but this, you have it down, facing downwards. Some people do it that way, but I think this is not good. I always make the drop line facing upwards.
Okay.
Yeah, because if you face it down, what happens is they bite on it, and it will get stuck inside the gum, because you have more dropping down. But you want it facing the occlusal surface. So you take it out, and you reverse it. Okay. And now it's facing upwards.
Okay.
So that's how it should look like.
So it's like this.
Yeah, that's perfect. Yeah. Now we have the option. Now this, in your case, that looks great. It's fitting just about fine. Sometimes you want to use Explorer to make sure it's tight here. You have an option of cementing, crimping like this with a crimper. You can just crimp it and secure it, and you're all done.
How you secure it?
You just crimp it like this. You push hard, and it squeezes on it, and it gets locked in.
Locked in with...
Locked, yeah. This wire gets like that. What I do also.
Oh, you lock it?
Yeah, you have to lock it in, because otherwise it's still loose. It will just come off. Yeah. So what I do is, yours was slightly shorter. You know what I do? See how it was like that, yours, right? What I do, I go like this, and oh, sorry, I did too hard, but I do it slightly. I just give it a little nudge, and it stays in the slot, but it rests against the space that you want. When it gets a little bit too short, I use the bend remover obviously for this, but let's say I did it here like you did, and it was slightly short. Okay, and I put it in there, and I notice that it is short. So what I do, I give it a little nudge with whatever instrument that I have, either this or an Explorer, and I go like this.
Push it
Put a little bit.
Yeah.
That's too much though. Get a little push. Now I have it where I want it. Now if I want to get the curve, I can get it a little bit more, probably on the other like that. So now it's a little bit longer, and I take it carefully without disturbing the thing. And then I crimp it by giving a squeeze here. See the squeeze? And then the squeeze here. You crimp it. Now it's not going to come off. It's locked in now. Even if you try to pull it, you can't even pull it. Even if you try, no matter how hard, it's crimped. So now it's secure. Now I have a space maintainer that's slightly longer. If I want it to fit like this, it won't fit because it's a little bit longer. But if I had it straight where I want it to be, I can cement it like that and it'll be all set. But if I what I do personally, I get this 3-point plier here, and I give it a curve. A little squeeze here. And a little squeeze here.
The curve right at the junction.
Yeah, right at the junction. So now we have a nice curve. Most of the time it depends. Sometimes some kids don't have a curve, and they don't have curve of speed, and it's like straight, and you want it to be straight. But most of the time they have various levels of curves. So now when you curved it, it got a little shorter, and now it fits perfectly. Now you get the, you tell them, you first try it with a pusher, you give a little nudge with a pusher, and then you're gonna have to many times you have to do your finger and go like that and like that to make sure like fitting fine. And then you tell them to bite. You tell them go ahead and bite. Bite on the distal, bite on the buckle, bite on this, bite on the buckle until it's seated.
What if they have a short tooth and this band is still like up the occlusion? What do you do?
What happens sometimes? What happens is if no matter how much you push it,
Right,
you still have. What I do, what I personally do, I know it's probably not really ideal, but what I do, there's something called festooning the thing, which means you bend it inwards into the groove. But what I do instead, I get a football burr on a high speed, and I kind of grind it a little bit. Yeah, I just kind of grind it and I just take it down, and it looks good like that way. Sometimes it happens even on the buckle. And if it's a baby tooth, it's not a big deal if you like take a little bit of the baby tooth on your waist. You're not like as careful if it's on a permanent tooth. But even with a permanent tooth, it happens more often on a permanent tooth. You can still grind it with a diamond football burr, and it will still look nice and fit fine. So now you cement it like this, and you got.
You do that after you cement it?
Yeah, after I cement it. After cement is hard. You could do it before if you want to. If you have the time and you want to do it before, that's fine. If you think it's already long, but that looks good enough. Yeah, did the job.
One question: how do you measure the distance after you fitted the band? You measured with this, or
Yeah. Now let me show you. Where's your typodon?
Which is up, which is downside.
Now the curve, you follow the letters. The curve is following the gingiva,
Okay.
and it should be seeing like with the lettering, the wording should be like always straight.
Okay.
Okay, so if you're on top and it's like this, facing up, the letters are facing up, the curve facing the gingiva straight like that. And the lower is the same way. So this is your typodon, right?
yes.
Okay, let me go to your
Sure.
place.
Looks like the case is it kind of lifting up when you bend it. It kind of lifting up.
Yeah,
It's
yeah.
not really going against the canine, just the surface of the canine. Is that okay?
What do you mean? Like?
It's kind of lifted up this way. It's not.
No. That's not. This is not ideal. Obviously, this is on a typodon. This is not ideal. Ideally, you want it to look like this. It has to be like this.
So you probably have to bend it back.
Yeah. No. In this case, because it is. What happened here is because it's a typodon, it's not a real tooth. But what happens with a real tooth, you tell them to push. And this is, by the way, she got a bend that's half a size bigger. This is not the right. You want to go half a size. That's the reason why. Yeah. Because if it's, this is a, you get 32. You would want a 31 and a half if you have here. Yeah,
You mean half size down?
half size down. Yeah. This is slightly. You don't have it, but that's fine.
That's too big. Let me see.
It's slightly too big. See, it's a loose.
Okay.
So, but anyway, but when you have it in a patient's mouth, you want to make it look like this, and it's different. It's typodon. The gum is different here. It's pushing this plastic rubber thing. Gum is pushing it up basically. But I will show you one that will look ideal right now. But that's basically how ideal. Here.
Obviously, when you do that, like, the patient is numbed up completely. So
They don't have to be numb.
they don't need.
No, unless if they're numb from the extraction on the same visit, then they're already numb.
Okay.
But if they're not, you could use tack. Just put some tack on it and leave it there for a couple minutes, or you don't even use anything. I don't need to use any anesthesia.
Is there any chance that the patient would feel some kind of like?
They're just pressure, not really. If they're not numb, they don't feel anything. Most of them, when I do it, they don't feel anything. No, just a lot of tail should do.
When you push their gums,
They don't feel anything. No, not really. No.
Yeah, I feel like they're gonna be in pain or something like that.
They won't feel much unless they're extremely. They're like really sensitive, hypersensitive. Then
Does that happen in a real mouse, or
here.
have to push down a little bit?
You have to push it down a little bit, see? And like in this case here, let me show you here. You got it, you want to make it slightly longer if you want. What you can do here, if you want to leave it straight, you can leave it straight. But when you, in the mouth, when you push like this, many times you have it slightly, tight, snugly fit, and you push it like this, and you have extra form of retention because now it's like snugly fit. You have to give it push to fit. So when it's snugly fit like this, it's less likely to be dislodged. And you make sure you go like this with the bite stick, of course, they have them bite with the tip of the triangle here. Bite, 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 and you get yourself a band that sits here like that. It will look like this.
Okay. So
And even if it's touching the gum, then that's fine. Don't even worry about it. But if you want to give it the curve that I was talking about, then you have to do it a little bit different. You have to crimp it, of course. This is not crimped, by the way. So this has a risk of getting loose coming out, because once you crimp it, then it will get locked in. This is not locked in; it come out. So what I did, I made it slightly longer. And I tried again. It's slightly longer now. I can crimp it. Crimp here, one squeeze here. One squeeze here. Now it's locked in and it won't come out. And then I give it a curve. A little curve here. A little curve there. See, you got the curve. And automatically what happened when it got curved, it got a little shorter at the
you
same
need
time.
to crimp this one, right?
You have to crimp every one. Once
No,
not this. No, not just this right here, the joint where it goes. And now you get it. You give it the push, and then you tell them to bite with the bite stick. It's mainly on a distal buckle, and sometimes I push it with my fingers. It's a little tight, and I get push with my finger and it goes down, and it locks in and has more of a retention that way.
Okay. So when you do the crown, you have to crimp the crown, but this
No,
you don't.
no, you don't need to crimp. Not the crown. No, not at all. Yeah.
Is this something?
Oh, there you go. I was going to come to you. That's perfect. Yeah, there you go. Yeah, that's excellent. That's the way to go. So now you have it there.
And just push it, right?
Yeah. Now, if you want, what I do at the end, what I was saying,
Yeah.
to make it look like it's custom made, after it's cemented, cement is still soft, I give it push here, see?
contoured.
It looked like it contoured straight, as if it was just made for that tooth. And the same thing here on the lingual. And sometimes even on the distal a little bit. Give it a little bit more flat contouring. And then to me, looks like it's not for that. But now that's a very nice space maintainer. But you didn't crimp it. You forgot to. Yeah. Okay. Now, if you want to do it with the curve that I was talking about, get the band remover first. Can I borrow your band remover? We can take it off here, like that. Okay. And then, in this case, if you want to give it the curve, you're going to make it slightly longer. So when you fit it, it's slightly longer than it should be. And that will, when you curve it, see now I want to curve it now. You can crimp it before or after the curve. Give it curve here, give it a curve there. Make it look nice and curved, pretty. And make sure it's crimped here, crimp there, and crimp there. And now fit it. See, that looks nice. See how nice it looks like? It followed the curve of the gingiva. It's resting perfectly against the molar, and it's fitting them, and you can cement it right to cement. See how beautiful that is? Many times I use my two fingers. It's slightly longer than it should be, maybe by a speck, by half a millimeter, but it can just barely fit. But I know if I use my two fingers and I manipulate it and I push it down, it will snugly go down and it will fit. Sometimes even if they bite on it with the bite stick, I have them bite on the bite stick because I see it's not finished, it's too long. Rather than panicking, getting frustrated, and thinking that I have to take it and make a new one, or take it out and crimp and cut it again and make it shorter. I don't do any of that. One or two things. Either I use a 3-prong plier to make it shorter by giving it a curve, make it automatically shorter, or I forcefully have them bite on it and squeeze it between the two teeth. And now you have almost like an active space maintainer, because what happens is that you have extra form of retention. Now the space maintainer is more retentive because it's resting snugly against those two teeth. So that's one way of handling an extra a little bit longer than it should be. Unless it's way too long, then obviously you have to do something. But if it's just by a little bit, slightly longer, that's the way to handle that. If it's shorter, and again, forget the curve, but if let's say you've done the curve, you can decurve it to make it longer. But let's say you're not doing the curve, forget the curve, and it's shorter, you're gonna have to take it out before you crimp it and do it and extend it a little bit longer, and then try again, make sure it fits, and then crimp it again. Now when you crimp, you squeeze really hard with that crimping plier on that tube, and that tube will really lock that wire inside it, so you can't take it off anymore. Now, what I also do is a little tip. If you don't want to take it out and extend it and thinking, because you really have to be really very steady hand to extend it, let's say by half a millimeter. What I do instead is, while it's still in the mouth, before I crimp it, I get an Explorer. If it's too short, right? It's too short by maybe 1 millimeter. I get an Explorer or any instrument or a spoon or whatever instrument you like, and I give it a little nudge from inside, from behind the loop until it hits the tooth. Once I give it, I don't get that nudge, it extrudes out of the tube, and it hits the tooth, and I know I have my right length. Then I take it out, I crimp it, and I can cement it. Any questions? Anybody have any questions?
Can we crimp it in the patient's mouth?
I don't recommend that, no. I may have done that very rarely, but I prefer not to, no, because it will make it too complicated. It's better to take it out. Don't do that.
Because when you take it out, you might again, like, it might go in.
Yeah. No, crimping the patient, no, I thought you meant, what I have done in the past, I may have used a 3-prong plier in the patient's mouth, but I wouldn't definitely not crimp in the patient's mouth. Crimp it outside, get it right. But what you do is, I'll show you the video again. You have to watch the video now after you do this, because you will get more, you will relate more to the video after you've done your experiments here. Because what I did is I pick it up very carefully, make sure it won't move on me, because if you pick it carefully the way I did here in the video, it will not really move, it will not get any shorter or longer. I wouldn't worry about it. And once everybody's comfortable with doing that space maintainer either on a first primary molar or on a second primary molar, we'll do a distal shoe. It's really important to do a distal shoe. Now with the distal shoe, it is kind of important to do the curve with the 3-prong plier. In this kit, there's enough bands to try it on a permanent molar with a bigger size band, either size 37, 37 and a half. Usually the common size of first primary molar, and you have to extract the second primary molar against it and do a space maintainer loading it on the first one like I did in the video. If you want to extract a first primary molar like a BL or S or I, then you would load it on a A or J or K, or which is the big second primary molar. You could load it on that and maintain the space for the first one, and it will be resting gate second. I think most of you did it that way right now, but I think I've seen only one or two who did it who extracted the second primary. You can extract the second primary if you want to do it like I did in the video. Now let's watch the video again. I think you will relate more to the video now that you've done this, and then we can make some comments on the video again one more time.
Using a bend technique the novel system. So by looking at this tooth, it looks like I would say it's about size number 37. If it's not exactly the same, you can always go back and get either a smaller or a bigger size. Trial and error sometimes, but sometimes you get it from the first trial. So 37 looks right now.
If you want to do the exact same one, like extract tooth T like I did here, you can go ahead and try it on your tummy if you have it. And do exactly what I'm doing here. So that was a 37 band.
Big hug with this, right?
Giving you a big hug. You feel the hug? That's what I told him always. You feel the hug? And when I push, I say you're gonna feel some pressure. You feel the push? Do you feel the push? So I'm always talking to them like I know exactly what's going on. No surprises. Eliminate the surprise element here. So now when we do this is a bed on a permanent molar. It has a wide loop, by the way. You need a wide wire. So on the kit, you see a slot for a wide drop wire, and that's what you need. You only need two types of wires, a wide drop wire or a narrow drop wire. They're both drop wires. Ignore everything else they have here. Ignore the rest and ignore the plain wire. So when it's a big tooth permanent molar, a wide drop wire. When it's a primary baby molar, it's a narrow. So this is a wide drop wire that's inserting like what we just learned, and inside those tubes, push it in there. And it shows everything. That was not a perfect fit, by the way, because I had to adjust it a lot, as you can see here. First, I tried it in, and it looked too short. It's too short here. See what I did? I took it out with my fingers. It was easy. I had a good grip on it. You want to take it with a band remover, you can do that. I made it a little longer, as you see here. And I tried it again. And it looks like it's a perfect fit. We have the right size. I extended slightly by 0.5 millimeter, just a little bit, and to overlap over the marginal ridge of that crown, just a little bit. And okay.
S, which has a crown on it. So all I have to do now is crimp it.
Then I crimped it. After I made sure it's just slightly over the edge of that ridge, marginal ridge of that opposing of the tooth S. Crimped it, that will squeeze it, secure that wire in place so it won't come off. I gave it the curve with a 3-prong plier because I intentionally made it slightly longer so I can give it that curve because we have a good curvous V here. So I give it a little bit of curve with the 3-prong plier like we just did. And I tried it again to make sure I didn't make it too short. It looks like it's fitting fine now. I got the curve, I got the crimp, I crimped it well, and I got the right size band, the right segment size for the space. So we're ready to cement. We dry it with a cotton roll. We squirt that cement in, or use even better a true glass iron cement like Ketex Sem or Fuji Sem, whatever you like. The glass iron cement will prevent decalcification because the fluoride is releasing. This one happened to be very easy. My assistants love that, but I told them to stop using it. Not only because the tips are too expensive when you use them for as a single band, but also this is a resin modified cement, and I prefer now to use a true glass iron cement like Ketex Sem. We dry it.
dry.
You don't have. It doesn't have to be bone dry. You don't have to be really perfectly dry. Just enough to have it in there, because the property of the glass aramid cement that it is forgiving with moisture. If you have a little moisture, it's not a big deal.
That's it. Now we have to just use the pusher.
Now use the pusher first to roughly put it in place, not fully. You don't expect to do everything with the pusher, obviously. Roughly with the pusher, and then when it looks like it's roughly in there, I use the bite stick that you had here with a triangle. The tip of the triangle goes on the edge of the band. She bites on it. It sits exactly where I want it to be. And you see, sometimes you can either, it was a little long. See how I had her bite on the loop? It was a little long, but that loop, when she bit on it, it squeezed it in between those two teeth. I got more retention now. You see that? And if I see that it is diving too close to the gingiva, guess what I do? I have her bite on the distal like I did here, and it will lift up the arm slightly like where I ideally want it to be. So when she bites on the distal, if it happens to be inclined too far towards the gingiva, but still tight, when you have her bite on the distal, and it's to have a lever effect, and we'll push it slightly upwards from the mesial, and you get it where you want it to be.
Is it okay, this subgingival? Are you leaving that subgingival, or
only this will show you love. This you don't need. You don't leave it.
the band?
The band, yeah, oh yeah. It's good. Actually, it's good to be subgingival. You want it to be subgingival. Yeah, definitely. There's no harm in having like a little bit subgingival. Now I'm doing that last thing about making it look nice and pretty by pushing while the cement's still soft on a groove to make it like it's just contour it basically. The last final wipe. And she's done.
See how fast I was? Fast and easy. Thank you very much.
Okay. So let's, everybody comfortable with that before we move on to the distal shoe? This is a little bit of a difference. Now for the distal shoe, we're going to extract a we have the patient did not erupt the first permanent molar, so we're going to remove the first molar that you have on the typodont and keep it in primary dentition, no permanent tooth. So unscrew the first permanent molar. Now you have a patient in primary dentition. Unscrew the first permanent of your choice, whether it's the right side or left side. And you have now a patient with primary dentition only without a permanent molar, and that's when we do the distal shoe. Once you unscrew that, you're obviously going to extract. We're going to extract the second primary molar, which is tooth A, J, K, or T. We extract it by unscrewing it from the typodont, and now you want to do a distal shoe before the first permanent molar erupts, to like we had in that slide. With a distal shoe, although I can get with the other space maintainer, I can get away without doing a curve with a 3-prong plier and make it straight if you want to makes life a lot easier for you guys. But with the distal shoe, I do need the curve. For the reason is because if I don't, I've seen other dentists, other pediatric dentists even, not doing the curve. And what happens if you have a curve of speed, depending how much of a curve of speed, most of the time you do have a curve of speed. If you don't put the curve like I did here, and you make it straight, this one is going to dive like this. The distal shoe is, although it may be hitting and doing the space maintenance and hitting the mesial surface of the premolar, but it will be going down and hitting the butt of the second premolar, and I've seen that very often. I wish I had actually. I have so many. I've seen on panorexes where they did not do the curve, and instead of going straight or like this, inclining like this, going like that. And here you have your second permanent premolar. I'm sorry. It will be hitting on the tip of that distal shoe, actually interfering with it. So that's why we need the curve here with a distal shoe. If everybody unscrewed the first permanent molar and the second primary molar, as if you have extracted a second primary molar before the eruption of the first primary molar. Now you want to fit a band. You're going to select a band from your kit that will fit a first primary molar. It's a smaller band, it's usually size 26, I think, 26, 25 and a half, maybe 20, 25. Usually the most common size for a band on a first primary molar for a distal shoe is usually 25, 25 and a half, 26, 26 and a half. Usually more, very rarely you get 27 if it's a really a big primary molar. So I think in this case 26, 25 and a half, not sure. Try the one that fits. Use a band pusher again to make sure it fits in the right place. And don't be frustrated if that doesn't work, if it takes a little bit longer than 5 minutes. 5 minutes to me has happened after so many years, but you probably book yourself for half hour and don't feel bad. You're still doing much better than doing 2 visits with a lab fee and sending to the lab. You still, even if you take half hour in doing this, it's definitely much better than 2 visits with a lab fee and all that.
Do you use a crown instead of a band? Does it mean a crown?
Yeah, I don't like to use the crown. They come with crown. There are kits that have the crowns, but guess what's going to happen? When it's time to take out the space maintainer and I want to keep the crown that's welded, now it is like you're stuck. You're going to have to cut it with a carbide burr and make this huge shrieking noise that kind of freak out the child. So I never do that. I would never, even though that's an option on some of the kits, don't put it on a welded crown. That's not the question. What I do is, by the way, that's a good question because I do put a band on top of the crown. If I have any where that, like in this case here, the video actually was different, but if I have to load the band on a crown tooth, then I would just pick up the right size band that will fit the crown. I don't use the extension that's already welded to the crown. It could be a big nightmare when it's time to take it out. So you can just fit a band as if, okay, there you go. All right, good. So now you extracted the tooth here. Now, it's a little bit longer. The tooth, if the bud, you can make it shorter here. Now, with the typodont, you don't have a tooth, so if it's longer, it's still going to work. But in real life, when you have a tooth there, many times, if it's longer, which is to your benefit to make it easy for you, it just won't go in. That thing, that extension, the distal shoe will not sink. It will hit something. You'll see it's hitting something. So you know it's not in the right place. Don't be frustrated. Don't think that you're not doing something wrong because it's actually helping you to tell you this is not where I belong because there's a tooth there that's stopping it from going in. So all you have to do is take it out, cut it, make it shorter, and then go exactly to the easiest thing to do is let the socket guide you. Let the socket guide you. So you put that distal shoe surface, that extension, right at the distal side of the tooth, where the extracted tooth was, and the distal part of that socket. Pretend that is the distal root of the second molar. Pretend that extension of the distal shoe is actually going inside where the distal root used to be before you extracted the tooth. So when you use that, you may want to push it right against the distal socket. And if it doesn't go in, it means it's hitting the bud of the permanent molar. It's right there. So you take it out, shorten it, and try it again. Okay, that's good. Now this is perfect. Now you want to put it inside the socket. You want I've seen a couple of people putting the distal shoe in the socket of the permanent molar. Don't put it in there because here you have nothing. In this mouth here that you have a permanent that did not erupt yet, you have nothing. You don't have a socket like here in the typodont. So you want to put it in the socket of the primary molar that you extracted, not in the other big socket, because in that area there's nothing there. There's tooth that's supposed to be erupting that did not erupt yet. So you want to put it, make sure it's contained. Even if it's a little squeezed a little bit, it has to be contained in the socket of the extracted tooth that you extracted. Okay. So now, in this case, I want to make it slightly longer, but it's still not too long to the point where it won't fit. And this is where actually, if anything, this makes it easier for you. Because what you're doing here is you're making sure it's contained in the socket, number one. It will tell you, if it's too long, it will tell you because it won't let you get in it. You just can't stick it in there because there's a tooth there. So you can shorten it until you get it where you want it, in the distal side without, and then you get once you establish the right length and you make sure it's not hitting the permanent tooth bud and everything is in the right place, you have enough span, and then you can crimp it with the crimping pliers right here. And then you give it the curve with the 3-prong plier. Give it a curve like this. Now you see a nice curve here. Now we know this is going to fit perfectly fine against the tooth. It will not go down to the second premolar, like I've seen in many x-rays with other ways. And what you're gonna find is automatically when you do the curve, because it flares out the surface. Now, please pay attention to this one because it happens very often, happens to me almost all the time. When you give it the curve, you automatically flaring. You see that the arm or that surface for the distal shoe is flaring like this. Now, when it's flared like this, you have more chance of it not fitting because it's gonna probably hit that permanent tooth that was there. So what you wanna do is stick it in there first, okay? You stick it in there before you put the band on the first primary molar. Once in there, then you go like this, and you kind of squeeze it in there to get into the seated on the first first primary molar. And this here, because it's all rubber and plastic, it will not be in the mouth. You have a more of a chance of doing it properly. It's not going to happen here because of the plastic and the rubber and on the typodonts. But what I do if I bend it, by the way, that's one of the tips I do. If it bent it out of shape because it didn't, I was having a hard time with fitting it, I go like this and I kind of reshape it, make it circle again with this, and then try it again. If I still finding a hard time fitting it, even though I did this, then I can make it slightly shorter by decurving it. Another example, another tip that really happens also. Sometimes you want to put the distal shoe and you have the permanent molar partially erupted. You can see only the mesial marginal ridge, like only maybe say 10% of the tooth is erupted, maybe 20% is erupted, but most of it didn't erupt yet. And there's no way, obviously, you could put a band on it. So you still do a distal shoe, but rather than you having a long arm like this that's sticking way deep in the gingiva, you want it short. So what I do is I get a diamond football burr, and I cut half of that arm, and also give it a nice curve, make it look nice and round. And all I need is enough surface to push against the half erupted permanent molar I can see, because I know now for sure if anything, it's easier because you have a shorter arm, impinging less into the gum, digging a lot less, and you can visualize exactly where that surface that you have on this distal shoe, where it is hitting against the permanent molar, because you're right there, you can see it with your eyes. So that's the other way.
Dr. Libby.
Yes, sir.
Question. If the permanent tooth is partially erupted and you see it, you want the shoe to touch the mesial of the molar, and if it's not, you want it to go on the sulcus of the primary tooth.
Yeah. Yes.
Mesial of the bone.
Yes. But what I would do is when I can see the marginal bridge, the mesial surface, I want to go have it rest against it. Because it serves two purposes. You can see exactly what you're doing. You're not working blindly like before. Before you're just estimating where it is, and although you're correct usually, but here you see it very well yourself. You know that as this tooth is erupting, it's going to slide on the surface. It's not going to go any mesial. It's not going to make you lose any space. And at the same time, you give it that snug feeling that you want to see. That snug feeling, if you just make it just about long enough so it will fit snugly and give you more retention.
On the mid-corona part of the molar, right?
Yeah.
It's wider.
Yes.
On the marginal ridge, on the mid part is just wider.
Yes.
Would that impede anything of the eruption, or you're still?
No, it will still erupt as long the way they call it contact point, right? If you have one point of contact, that's enough to maintain the space. That's all you need. Here you have way more than that. You have really nice white surface, and that's all you need to maintain the space. And if you cut it like I do, usually it takes you a few seconds to cut it, to like shape it, and I give it also like a round surface with a diamond burr, a football diamond burr, and you have it resting right against the molar. You can just push it snugly where you want it to be, and get that effect that you want.
And if you put it there like you have it in that X-ray, you remove the band. If you can't see the tooth coming out, when will you remove the band?
Yeah, when the tooth is fully erupted, then you can remove the band and make a normal band loop space maintainer.
if the bicuspid is erupted.
If it's not, if it's erupted, you don't need it, obviously.
No, here, if the bicuspid is erupted.
No, once it's erupted, I mean, it's not going to erupt until this one. This one goes way before the bicuspid. So this is going to erupt first.
Right.
Once it's fully erupted, you could load the space maintainer on it here, like we did in the video.
Okay, and then.
And put it here. And you don't need this, and you can take this out.
Okay, that makes sense. Thank you.
Sure. Oh wow, that's pretty. That's perfect. Now, see, we got someone who did it just perfect, exactly the way it should be. If anybody wants to look at it, she just did it really nicely. You see how the distal shoe here, you want to pass it around. She got it. She got the distal shoe contained in the socket of the extracted tooth. She gave it the curve. It's exactly where it belongs. It's not too long, not too short, and it's ready to be cemented.
And that curve is okay?
Yeah, the curve is fine. It's not. It could have been a little bit more, but this is acceptable. I see the flare. See, I see the flaring effect. That's what we want. That's good enough. That's really nice. Now, what I do on this note, when I have a tooth like this, after I cement it, I'm not sure if it's still loose. I'm not sure. It doesn't look like it looks like it's going to come off any second. You know, I do something. Patients cooperative, granted, which is a lot of them are cooperative, or I'm in the OR where they're sleeping already. Is I etch after I cement and everything. I etch and bond and put flow around the edges to seal it, to seal all that cement in there. And I find that to work, and it won't, because sometimes this come off if you don't have it really. Yeah, and the more you want it deeper into the gum, and subjectively, the better. The more like, yeah, if you have it like this is, I would say this is not ideal as far as this. I wanted to go subjectively, so it's less likely to be dislodged.
But if you sealed it with the flowable later on, when you remove it, you gotta first take it off.
Oh, it comes out in 1 second. No matter how much flowable you can load it, it'll come in 1 second.
The more you curve this one, the more distal that was.
Correct. It goes fluid and it starts kicking in, so you have to be careful. You have to kind of measure that.
You have to make it shorter, right?
Yeah, you have.
I feel like once I bend it,
slightly. Correct. You got it. You got it. Exactly. That's exactly what it is. Now, what I also do, if it gets a little bit too long, but not way too long, and I feel I can't fit it, what I do is I first stick this in the socket and then go like this and then go like this, push it. I have a snug feeling. One thing is I do is sometimes, that's just me, and I don't know if you want to do that, but and if of course, I have a cooperative child who's doing well, and I find that the band, because it's not always exactly the perfect fit, although you have the half sizes, sometimes no matter what you do, it's either slightly a little bit too big or slightly a little bit too small. What I do is I have a concern that I'm worried that it's going to be dislodged. After I cement it and I dry it and clean it, everything, before I dismiss the patient, if they're cooperative, or if I'm in the OR, if they're under general anesthesia, what I do is I etch around the periphery or the bands, around the bands, and I bond and I put flowable composite to seal in the cement in there, give it more. I don't know if that works. It's just my thing. It's just an extra form of retention. And I think I've seen a few of them coming back like a year later and they're still in place and the flowable is still there. So maybe there's something added, maybe it's just to make me feel better. But I don't know if no scientific data to back it up. It's just what I do sometimes if I feel like it's not 100% secure. You always have to tell the parent that to avoid sticky food, like especially sticky candies like Starburst, caramel, toffee, chewing gum, fruit snacks, these things that could make them come off. If they come off, and don't be frustrated if they come off, because it happens even with the best of us. It happens to me many times that they come off because they either chew something, or most of the times I actually had a situation where the mom denies it, that, oh, he was just eating a piece of bread or gel or something soft, and I asked the child, say, yeah, I was chewing gum. So of course, sometimes they just don't tell you what it is, but don't feel bad if it comes off. It happens to us. Just re-cement it. You can actually, it's charged. There's a code for re-cementing a space maintainer, and there's a code for removing a fixed maintainer. You charge for that. That's your right. So when it's time for the new tooth to come in, and you remove the space maintainer because the premolar is erupting, you remove that space maintainer and you charge for it. There's a code for that. You re-cement the space maintainer. You're coming in as an emergency because the space maintainer is dislodged for whatever reason. You do charge for a limited exam. You examine the patient, decide what's going on. You take out the band, the space maintainer, you re-cement it. You charge for re-cementing a fixed maintainer. Those two charges are, you're right, very much legit charges if you have a patient coming into your office for emergency for losing a space maintainer.
Dr. Libby,
Yeah.
what is the code used for the unlimited exam, you say?
What's the limited exam code?
140.
140?
0140?
0140.
And that's for any visit?
Any visit that comes.
It's not a periodic?
Yeah, exactly, absolutely. Yeah. Any visit, they have a question about something, they have a space maintainer, they have a tooth that's bothering them, an emergency visit, you do an extraction, you can charge it with whatever you do on that visit, whether you do an extraction, re-cement a space maintainer, you charge for re-cementation of fixed maintainer, you remove a space maintainer that's bothering them that another dentist did, you charge for removal of fixed maintainer, there's a code, do you remember?
1550.
155 what?
50.
1550 for removal of space maintainer. And for re-cementation of space? 1555, you have to re-cement a space maintainer. The same thing with crown, by the way. If you re-cement a crown, you charge for that. There's a code for re-cementing crown. Even if it's done by another dentist at stainless, you can own a primary tooth the same way. Everybody's familiar with the distal shoe? Anybody has any questions about anything that we've discussed with distal shoes? Or yes, sir.
So if you put the band in a permanent molar,
Yeah.
in the future you want to remove it.
Same thing with the band remover. You grab the band remover and you give it a little push like this. Don't be timid to give it a little hard. Sometimes they come out, scrape it. Sometimes they feel the scraping noise. They get a little panicky, but you just calm them down and give it like that, and it comes off in 2 seconds, no matter what it is. First permanent, first primary, second primary. The easiest thing to do is to take it off. The easiest thing. Sometimes the cement may get stuck there. If you have good cement that's really stuck to the tooth, it may give you a little hard time. It may slide, that edge on the band remover may slide on the metal of the band, and it makes a funny noise and gets a little frustrating. You may have to try it 2 or 3 times, but eventually it will come off very easily. Simple.
I saw like Fuji cement which is permanent cement.
You do use any cement you want, but obviously almost every cement now is glass ionomer cement. I don't know, that's what we use, unless the old cements that didn't have a glass ionomer in them, they're probably outdated. So every cement is glass. Any glass ionomer cement will work. Because of fluoride release, you want the fluoride releasing aspect of it. Please make sure you fill the evaluation form. It will be very helpful for us. We greatly appreciate it. Thank you.
Thank you.
And yeah, you can just leave it here. Everybody's all set? Thank you, everybody, for coming. It was a great pleasure having you here today, and I hope that was helpful. Hope you apply that at your practice. And any questions, please feel free to email me. You have my card. You can email me on my card, and you can call me anytime you want about any patient in Pedo in general. I'll be more than happy to respond to your email or answer your phone calls. Thank you again.